All right. Hello, everyone. Uh, Today, alongside me, Shanika and Ariel and I are going to be presenting to you on OCD and its relation to CBT. So, without further ado, so to start it all off, I know that all you bright individuals probably had an abnormal psych class in your time and are all experts on OCD, but just in case you need a fresh reminder, um, I'll just quickly go over some of the characteristics of OCD. So, what is OCD? So, the DSM-5 states that OCD is characterized by obsessions, compulsions, or both obsessions and compulsions. So obsessions can be thought of as these repetitive, unwanted, intrusive thoughts or images that an individual experiences. And in most individuals, this causes an increase in the amount of distress they're experiencing, and increases amount of the anxiety they experience. And then compulsions are more behaviors. They're more of these acts or rituals that the individual feels compelled to do um, as a result of either an obsession or some sort of rule that they've internalized. And these compulsions are usually so the individual feels a decrease in the amount of distress that they're experiencing or a decrease in the amount of anxiety that they're experiencing. So um, I kind of like to think of obsessions as far as like ABC goes. Obsessions can be thought of as the A as an antecedent because these obsessions lead to the anxiety being provoked, lead to distress happening in individuals with OCD, and then compulsions can either be thought of as either the behavior or the consequence as a result of um, the anxiety levels spiking in an attempt to minimize the distress that the individual is going through. So OCD does have some specifiers. They include with good or fair insight, with poor insight, or with absent insight or delusional belief. Insight is very important to understand an individual living with OCD, to understand how strongly their beliefs are behind the rituals. If they believe that what they're doing is valid, what their fears of happening if they don't do their rituals are valid, it's much harder. They have a lower prognosis than someone that understands that these behaviors might be inappropriate, but just are compelled to do them. And then finally, the last specifier is just tic related, and this is talking about if the individual is either currently or in the past lived with some sort of tic disorder. So this presentation slide is just to talk about how OCD is very rarely on its own in an individual. So nearly 50% of all individuals living with OCD have some sort of anxiety disorder as well. It could be a good reason why OCD was listed as an anxiety disorder at one point. Other notable comorbidities include major depressive disorder, and then, of course, Tourette syndrome and the tic disorders that I just mentioned. It's interesting to look at OCD and how it differs from other disorders. I'm specifically going to be looking at depression and anxiety. So with depression, we like to focus in on those depressive ruminations when comparing to OCD. These ruminations, they tend to be more negative, more pessimistic, and the individual really isn't necessarily trying to suppress these thoughts. They're just experiencing them. Whereas with an OCD, these obsessions are not inherently pessimistic. They're not inherently negative, and as a result of them, they're going to be trying to, or most likely will try to suppress these obsessions. So as far as OCD and anxiety, of course, they are very similar. However, the difference between them is anxiety tends to be ego-syntonic, whereas OCD tends to be ego-dysyntonic. So with anxiety, the individual tends to believe that their concerns, their fears, their worries, that they're very valid, that they have a very likelihood of happening to this individual, that these are concerns with high priority, or not high priority, but high relevancy. Whereas with an OCD, again, it depends on the specifier, but it tends to be thought of as this obsessive thinking is tend to be thought of as unrealistic and inappropriate. So in front of us is a couple of different models used to explain anxiety and its approach to treatment, or excuse me, not anxiety, OCD. That's what this presentation is about. The first one is Mauer's, this very famous 1939, the two-stage theory. It was later adapted to OCD, but I still think it has some relevancy. So stage one, it talks about how stage one is where the individual interprets a neutral event and then associates it with something that invokes anxiety. So they're conditioned to where this neutral event causes them distress, causes them anxiety. Stage two, the individual learns avoidant behaviors in order to escape this neutral event that now causes anxiety, to avoid the anxiety. As far as OCD goes, avoidant behaviors can be hard for those individuals because of the anxieties that can be taking shape. For example, someone can associate their living room with an increased anxiety, their laundry room with increased anxiety. So those are obviously a little difficult to avoid. As a result, these rituals and compulsions take the place of avoidant behaviors in order to cope with that anxiety. So there's also these 5 dysfunctional assumptions. I'll just read them off real quick. The first is having a thought about an action is like performing the action. I'll get into that in the very next point with TAF. Failing to prevent or failing to try to prevent harm to self or others is the same as having caused the harm in the first place. Responsibility is not attenuated or accentuated by other factors. For example, the low probability of the occurrence. 4 is not neutralizing when an intrusion has occurred is similar or equivalent to seeking or wanting the harm involved in that intrusion to actually happen. And then the last one is one should and can exercise control over one's thoughts. Very often, individuals with OCD will try to control, suppress the thoughts, when in actuality that is pretty harmful. The idea that they control, that they can stop these obsessive thoughts can be hurtful to them. So as I briefly mentioned, Rockman in 1998 came up with TAF. That acronym stands for Thought Action Fusion, and that's this belief that having a certain thought will actually increase the chance of a negative event occurring. So, for example, having the thought that an individual's girlfriend will come to harm, having that thought over and over and over again will lead to an increased likelihood that that individual's girlfriend will come to harm. So that will then in turn lead to an attempt to suppress that thought, get that thought out of their head because they don't want their loved ones to come to harm or whatever, which then actually does the opposite of that. It increases the undesired thought, and that obviously increases the distress, the anxiety along with it, and that's where this vicious cycle comes into play. A couple more. Foa and Kozak, a famous study in 1985. As far as how it relates to OCD, an individual with OCD differs due to an impairment in deciding the likelihood of harm. That's what they stated. So rather than seeing an event and noticing the absence of danger and assuming safety, an individual with OCD will see something, see an absence of evidence of safety, and then assume danger. One notable last little tidbit is Schur, Frost, and Otto in 1983 They propose that individuals with OCD actually suffer from deficits in memory, resulting in the repetitive rituals to make sure they ensure that safety. However, this is not very strongly supported by any of the evidence.
Now let's talk about what treatment looks like for people that have obsessive compulsive disorder. The gold standard, if you will, of OCD is exposure and ritual prevention, which is also known as EXRP. And here are the facts about it. So first of all, what is EXRP? EXRP is the prolonged exposure to obsessional cues and strict prevention of rituals. So what that means is we are actually exposing people with OCD to the things that they are uncomfortable with, and we are trying to prevent them from doing the rituals that are associated with them. The treatments also aim to block these rituals. Okay, so we're trying to taper them down, and we'll talk later about how one tapers. And then also repeated prolonged exposure to feared thoughts and situations provides information that disconfirms patients' mistaken associations and evaluations, and thereby promotes habituation. What's habituation? Habituation is when we see something as human beings and we have an emotional response to it, but as time progresses, that emotional response starts to taper because it becomes normalized, because we get used to what we're seeing. So that's exactly what we want when we treat people that have OCD. We want them to get used to what it is that they're seeing, regardless of how uncomfortable it might be, because we want to start to try to normalize those responses. Also, exposure exercises are often done in vivo, which is real life settings. So if we need to go to the person's house, if we need to go to their job, if they come into our workplace, into the office, and it's still effective, then we'll do that. But we want to try to target the in vivo spaces. Lastly, exposure is usually gradual. So patients will confront situations that provoke moderate distress before confronting the more upsetting ones. So that makes sense. If you think about somebody, for instance, who has a fear of heights, totally different, and you put them in front of a ladder and you say, okay, you have a choice of either stepping onto the first rung or onto the very last rung or the highest rung, they're probably going to choose the first one because they're uncomfortable with it, but they're not as uncomfortable as going up to the highest, right? So that's exactly what we're doing here. We want to start gradually by saying, okay, we'll step on the first rung, then we'll go to the next one, then the next one, then the next one, until we reach the highest one. An example of these things would be Dr. Josh Smith, who is an adjunct faculty member here at Spalding University. He treats a variety of things, even though he specializes in autism and people really, but children who are on the autism spectrum. But he shared a story with us one time when he was treating somebody that had OCD. He was called to the person's house, and that is the example of in vivo. So this child that he was asked to help had a ritual of making and stripping his bed in the morning 93 times before he could leave his room. So that was his number. 93 times is what he had to do before he felt comfortable with leaving. So when Josh showed up, he actually asked the client to strip the bed and remake it 92 times. Okay, so that's the example of the moderate approach. He didn't ask the child to make and strip the bed one time, which could have been too much of the exposure for him. So 92 times was day one. And then he asked the client to leave the room, and then he locked the door so that the client could no longer go into the room and finish the ritual. When he came back the next day, the child's instruction was to strip and make the bed 92 times. And every single day that he showed up after that, it was one less time until they got to him making and stripping the bed one time. That was it. And that's the example that we use. That's an example of treatment that we use when it comes to EXRP, to moderate exposure, and in vivo. So how do we know EXRP is really the gold standard of treatment? We know by comparing it to other types of treatment. So EXRP is made up of two components, exposure and ritual prevention, as I said before. Very much like CBT in that it has two components that are jam-packed together to create this beautifully packaged treatment method. So we compared EXRP to just exposure, and then we compared EXRP to just ritual prevention, and this is what we found. Patients in each condition of just EX or just RP were found to be improved at both post-treatment and follow-up. So what we know is that people who are treated with just exposure and people who are treated with just ritual prevention still show positive results. Patients who received just exposure reported lower anxiety when confronting feared contaminants than did patients who had received just ritual prevention. And then finally, the ritual prevention group reported greater decreases in urges to ritualize than did the exposure patients. Then we look on the other side of EXRP together, and we find that EXRP was superior to the single component treatments, so that's just EX and just ERP, on almost every symptom measure. How do we implement EXRP? These three things that you see in a circle kind of go together, so I'll just talk about them together. So first, promoting abstinence from rituals is essential for a treatment outcome. Okay, so that means regardless of whatever it is that you do, you have to have some type of prevention of rituals in order to expect positive outcome. And then the last two, physical intervention to prevent patients from ritualizing is no longer supported, and the preferred method of RP has changed over the years. So the preferred method used to be physical intervention. That could have been a family member, it could have been a psychologist that was literally physically intervening when somebody attempted to perform these rituals. And what we found over time as it's too strong of a coercion for the patients, and what's more effective is giving direction and encouragement. Some other things to consider. Patients prefer the gradual approach. So if you take that latter example that I told you before, that makes the most sense, because if we're going to expose you to something that you're uncomfortable with, you'll probably be a little bit more apt to accept it if you do it in increments versus flooding somebody with what they're uncomfortable with. Also, patients must approve all exposures prior. Okay, so what that means is I sit down as a psychologist with a potential client and say, okay, client who has OCD, this is what we're going to do to treat you. I want to do step 1, step 2, step 3. And while they may be uncomfortable with it, they have to approve that before we start down that treatment path. Even though it's something that they're going to be uncomfortable with, they have to give us the permission in order to go forward. It's not something that we can just spring up on them one time that they show up for treatment. Given that, they should also confront the highest item on the treatment hierarchy relatively early in treatment. Okay, so if we go back to that latter example, I can say to you as a patient, okay, yes, I do want you to work up to getting onto the highest rung of the ladder, but we need to do so relatively early. And relatively early means within about the first week, which is definitely exposure. But the reason why we want to do that so early is because that highest rung on the ladder, the one that you struggle with the most, is what we're going to continue to focus on throughout treatment for the majority of the time. So we spend this small amount of time working you up to the highest rung by getting you on the first one, second rung, third rung. And then once you get up to that last rung where it's the most challenging for you, that's where we're going to spend majority of our treatment focusing on that. The third box over here, duration is important. Prolonged continuous exposure is more effective than short interrupted exposure, right? So that makes sense, because if you're uncomfortable with something, you're dealing with it in the moment, and then you take a break from it, 9 times out of 10, what's going to happen is when you go back to that, you're going to start at that basic level again, where I have to go through all this work of being uncomfortable again. And we don't want to do that. We want to keep building upon the work so that we don't have any regression. And lastly, this is CBT's approach, or CBT's perspective on it. Whether patients are anxious is less relevant than what they do when they are anxious, since ritualizing and avoidance maintain fear down the line. Okay, so CBT is saying you're going to be anxious anyway. That's just characteristic of this disorder. So what we're going to do is we're going to maximize what happens while you are in that anxious state. Here are some other treatment approaches, and we're comparing them to EXRP. Intensive individual EXRP, which Ariel will talk about later, is EXRP, but it's a focused individual experience. We also have group EXRP, you have family involvement, and you have cognitive therapies. All four were found to be effective. Intensive individual EXRP tends to be more expensive, and it could also be harder to find somebody who is competent, a therapist or a psychologist who's competent in giving that treatment. Group EXRP is cheaper, but there also is a slower reduction of symptoms. Family involvement, that could just be the support of family, the support of a loved one, the support of a spouse. So what we're doing is integrating family involvement with intensive individual EXRP, and that was not found to have any type of effect, positive or negative. And then with cognitive therapies, what's been found is it's difficult to discern the difference between cognitive therapies and intensive individual EXRP, and the reason is they both focus on the same thing. They both focus on maladaptive beliefs. So with cognitive therapies, we know we're looking at schemas, we're looking at automatic thoughts. And then the intensive individual EXRP, we're looking at the rituals that happen, and we're looking at why the patient believes the ritual needs to happen. Usually it's because if I don't do this ritual, then this negative thing will occur. So that's also a maladaptive belief. And then finally, you have the use of medications. So clomipramine, which is also known as CMI, has been FDA approved to treat OCD. You also have your selective serotonin reuptake inhibitors, which is known as SSRIs, and they have been approved by the FDA as well. Up to 60% of patients respond to treatment with SSRIs. And when it comes to efficaciousness of CMI, the amelioration of symptoms continues only if the drug is continued. 90% of patients relapse within a few weeks after being taken off of CMI. And then finally, with pharmacotherapy, there's clear evidence that both CMI and EXRP treatments together are effective, but no study has found clear long-term superiority over EXRP alone.
So here I've just listed out a couple of assessments that are used to evaluate an individual with either potential OCD or their severity of their symptoms. I won't go too much into them because typically they're very generic and broad range, and what tends to be more important is on the next slide, which is the interviews with the individual. So the interview, the first meeting, there's 3 goals that are set aside. The first of which I will go into more over this slide and the next one, but it's to collect the information that would be necessary for the treatment plan for the individual. OCD arguably could be presented in the most unique sense out of almost any disorder. Not only do they have obsessions that could be unique to themselves, but also the compulsions that could be unique to themselves as well. So it's all about identifying the cues, the rituals, the behaviors, the compulsions, the obsessions. All that good stuff needs to be hashed out and detailed in the initial interview. So another important goal is to establish the therapeutic alliance. Obviously, the client needs to have a good deal of trust with the therapist if they're able to be able to work on these things and be in settings in which their anxiety is going to be heightened. And finally, The therapist needs to establish and evaluate the level of insight that the client has of their own symptoms. As I mentioned earlier with the specifiers, if it's good or fair insight, poor insight, no insight, that sort of thing. So the first of the things that needs to be established is the external versus internal threats. Fears are threat fear cues. So the goal is to establish and find the root of those fears, whether it's driven by an external or internal force. And that can be a little bit difficult because of that, of the TAF that I talked about earlier. The whole thinking about that idea will increase the likelihood of that happening. So this part especially requires a therapist who is going to be warm, reassuring, patient with the client, because they might have some difficulties even talking about this sort of stuff. So another thing that needs to be discovered is the feared consequences of the client. So what will exactly happen, what the client thinks will happen if they don't perform their rituals, if their compulsions are true, or excuse me, if their obsessions are true, if they don't enact on their compulsions. And then that leads into their strength of their belief and its consistency. So again, with the specifiers, seeing how much they think that their behavior is actually inappropriate, or how much it is actually valid that they're doing all of this. Another important step is identifying those avoidant and ritual behaviors. One step to do this is perform certain mini experiments with your client or with the client. So what the therapist will do is they'll create an event that they know will induce anxiety in their client, and then if the client does not do a certain behavior that the therapist has either asked them to do, or they've said themselves that they're not going to do, and then this lack of behavior actually causes them significant distress, it causes them more anxiety, it's likely that this avoidant behavior could be due to their diagnosis of OCD and should be targeted as far as treatment. This leads into the important discussion of remaining wary of substitute rituals. So often when treating OCD, individuals, when they're treating specific rituals, will come up with a different behavior or different action that will substitute that. This can get a little bit messy too, because it could go from a more external behavior to a more internal behavior. So it really requires close monitoring throughout the process of this, and making sure that no other substitute rituals are popping up as a result of this treatment. Another thing to include is the history of the problem and any past treatment. It's really important to know if the individual has ever gone through any treatment before for their OCD, if they've ever had any medications before for their OCD, that sort of stuff. The history can be a little bit complicated, considering that it might not be very detailed, because their symptoms could have begun very subtly. They might not have noticed them right away, and it's just become a gradual increase in severity over time. Another thing to note is their social functioning, their social support, really basic stuff as far as how does this affect their work, how does this affect their social life, how does this affect their relationship with their friends, their family, what roles do their friends, their family play. As Shanika noted earlier, family intervention could be a notable treatment for these individuals. Another super important one is their mood state. As I mentioned earlier, depression has a high comorbidity rate with OCD. So if the individual is going through severe depression, that would need to be treated first with some sort of medication in order to have any sort of effect on the treatment on OCD. And then finally, and obviously, the decision on treatment for the individual needs to be a collaborative process between the therapist and the client. The client may have beliefs that would not let them feel comfortable with taking medications. As Ariel will point out, intensive treatment is very time consuming. It can take multiple hours over multiple days, and that is not obviously feasible for everyone. So coming up with a good treatment plan that both the therapist will think will be beneficial and the client thinks is realistic is very crucial to this process.